Okay, hello again. I'm Dr. Idarsal. Uh, so this is a continuation from part one. This is part two of an approach to the critically ill patients. So, initial assessment and monitoring has goals. The goals are correcting this all the physiological abnormalities and you know and takes precedence over arriving at an accurate diagnosis. So, as a minimum, following physiological observation should be recorded at an initial assessment and as part of routine monitoring. So you have to correct the heart rate, you have to assess the respiratory rate, systolic BP, consciousness, oxygen saturation, temperature, glucose level, and urine output, arterial blood gas analysis, all these things, and also the pain assessment. So you have to assess all these things, including a base deficit and lactate level, by using arterial blood gas analysis. So you have to assess all these things. The other is you have to categorize patients based on their potential illness, okay? Based on appearance, neurologic status, respiratory and cardiovascular condition. So based on appearance, we can classify neurologically potential critical illness as non-critically ill, potentially critically illness, and critically ill. So if the patient is gray, blue, and motile, so these patients are critically ill. So patients who are anxious, who are sweaty and pale patients, these are potentially critically ill. So normal appearance patients are non-critically ill. When it comes to neurological assessment, alert and cooperative patients are non-critically ill. Patients who are confused, agitated, and eye opens only with voice, okay, are potentially critically ill. If the patient does not open eyes with voice and unresponsive, these are critically ill patients. So when it comes to respiratory rate, the normal is between 80 and 20. If the respiratory is less than 80 and the higher one is between 20 and 30, and these are the potentially critically ill. If the respiratory is greater than 30, agonal respiration, use of accessory muscles, or silent chest, such patients are critically ill. On cardiovascular condition, pulse rate between 60 and 90 is normal. Systolic BP greater than 90 with urine output of greater than 0.5 ml per kg per hour. These are normal patients. So potentially critically ill patients are heart rate greater than 100 and patient is in shock with systolic BP less than 90, urine output less than 0.5 ml per kg per hour. These are potentially critically ill. So especially patients are, if the patient is anuric, systolic BP is less than 60. Remember, this is but a very severe hypotension. So if the systolic BP is less than 60, heart rate is like greater than 150 or less than 50, severe bradycardic or uh, severe tachycardia with greater than 150. These are critically ill patients. These are critically ill patients. So the other is you have to know also the ABCD approach. So we have to approach those critical ill patients by ABCD approach. Okay. So A is airway, and sorry, there is some. So the ABCD approach has four interlinked phases. One is preparation before seeing the patient. So especially this is in the mass casualty, you have to prepare the team before seeing the patient. The second one is primary survey, and the third one is secondary survey, and the fourth one is definitive management. When you come to preparation, you have to gather information based on ample history, allergy, medication, past medical history, last meal, and events leading to the presentation and the environment. So previous primary care and hospital records has to be seen, and the other thing you have to ask the relatives about this information. The other thing is managing resources. So identification of available resources is important. The human resources, the material resources based on the mass casualty. The other thing is especially the staffs. You have to know your staff. You have to the capacity. You have to know identification of roles and responsibilities. You have to have division of labor or communication properly. So this is important. Then the second one is primary survey. Primary survey includes ABCD approach of approaching the patient. So after that, they will investigate the patient and they will go to also the secondary survey and they are assess also the you may return to the primary survey. The other is intervention simultaneously. It takes 5 to 10 minutes unless life-saving intervention will be done. When it comes to primary survey, you have to have a ABCD approach. You have to assess the airway. You have to ask the patient for the ask his name, for example. And also you have to, if the patient responds, then the airway is patent, then you will go to B. And if the patient doesn't respond, so you will see for the secretion and airway edema or any foreign body, and you will have to remove. The other thing is you have to secure chin lift and jaw thrust maneuver if the patient has no spinal injury, but if you suspect spinal injury, you will go to, you have to put the patient on the cervical collar. And the second one is you have to go to the breathing. You have to see, assess the breathing, whether the patient respires or not, whether the patient has, the breathing, whether there is paradoxical breathing or not, suctions. And also the other is circulation. You have to assess also the circulation simultaneously by palpating the patient. You here this patient is seeing the respiration, and also at the same time this patient is palpating the brachial artery, so you can assess simultaneously at the same time. So this is a BCD. If the patient is unconscious, unresponsive, and is not breathing normally, then you have to go to immediately to the CPR, because these patients are unconscious, unresponsive, and is not breathing normally. You have to go to occasional, even if the patient has only occasional gasps and which are not normal, start the CPR according to the resuscitation guideline. As you know, the CPR approach is CAB approach. You can go to CAB approach. Primary survey, when it comes to airway in detail, look for sign of airway obstruction, secretions, especially in the ICU. You see for secretions, the blood vomitus or foreign body. You have to gently suction under direct vision, and you have to assess the airway for any obstruction or any paradoxical chest movement or abdominal movement. You can see also on the mechanical ventilator for the airway pressure. You can also assess the use of accessory muscles on respiration. The other is central cyanosis is a lay sign. So it is a lay sign of air obstruction. You have to act emergently. So listen airway noises for any gurgling sound, snoring, hoarseness, wheezing, stridor, or silent airway. So you can do a chin lift and jaw thrust maneuver, especially if the patient has no any cervical injury. You can put also oral airway based on the patient condition. Untreated airway obstruction lead to lowered arterial oxygen level, so risk of hypoxic damage to the brain, to the kidney, to the heart, and to the will result in all these things, and there may be also cardiac arrest and deaths. So simple method of airway clearance will avoid all these complications. For example, airway opening maneuver and airway suctioning and insertion of oropharyngeal and nasopharyngeal or airway may avoid all these things. So principal indications for emergency advanced airway and ventilation techniques. So when the patient have apnea, oxygenation and ventilation, when there is raised ICP, so these are the indication for emergency advanced airway. If the patient is apneic, so if there is any increased ICP, potential environmental risks, especially in ambulance transfer of patients to for CT scan imaging. Also if there is any air obstruction, inability to maintain airway with simple maneuver, especially with chill lift and jaw thrust maneuver. So the other is for any facial trauma, uncontrolled vomiting, or if there is bleeding. The other is for those who have lower GCS less than 9. Potential for subsequent clinical deterioration like facial airway burns. So if this patient has subsequent deterioration, you have to put the patient on the oral airway or nasal airway. This is the ICU approach of patients based on non-intubated and intubated patients. So, sorry, for intubated patients. So, see for the previous, you know, 82 deeps and also see for the pivot for any cuff leak or not, or for any cuff may be deflated on maybe deep or maybe extubated. So see for that. The other is position of the head. Ensure no extreme tilting left or right. Check for 82 deeps and adequacy on the previous documentation with reference to previous documentation. Also seek for the technique of the block detectable with glottis or crust secretions, and also you have to rinse with 2 to 3 ml of normal saline, and you have to secretions gently. You have to also assess the regularity of secretion and type of secretion. The other is do cuff leak test if suspect of laryngeal edema. So when you come to breathing, although airway evaluation always takes precedence, often the airway and the breathing are done simultaneously. Clinical assessment of ventilation and oxygenation. Do movement of chest normal or abnormal, use of accessory muscle or not, or agonal breathing, abdominal breathing. Listen for the breath sounds or and added sounds. You have to also feel position of the trachea and the symmetry of the chest. You have to also adjust the pulse oximetry and capnography. See the capnography. So these are the clinical feature of inadequate oxygenation. The patient will be restless, delirious, drowsy, cold extremity, cyanosis, tachypneic, arrhythmic, hypotension. So breathlessness. These are clinical feature of inadequate oxygenation, and this may not be due to the problem of respiratory. So the problem of respiratory will guide you. The patient will maybe breathless, maybe tachypneic, inability to talk, open the mouth, and there may be flaring of analysis, there may be use of accessory listen, there may be use of paradoxical breathing. But there may be not be arrhythmia, hypotension, tachycardia, or drowsiness, or any explanation other than the respiratory. So warning signs are if the respiratory is greater than 30, unable to speak 1 to 2 sentences without pausing. So agitated patients, cyanus patients, pulse oximetry shows less than 90 with greater than 60 of oxygen, deteriorating despite therapy. All these will are warning signs. So you have to give oxygen at high concentration. Provide high concentration oxygen with a face mask with greater than 10 to 15 liters using face mask using a reservoir. So if the patient's trachea is intubated, give high flow concentration of oxygen with self-inflating bag. So in acute respiratory failure, aiming to maintain the oxygen saturation has to be between 94 and 98. This is the target. In patients at risk for hypercapnic respiratory failure, aim for the oxygen saturation is lower than the previous one, that is between 88 and 92. So, especially in patients with chronic respiratory problems like COPD, chronic asthma, this may be the target. So, also here, this is the diagram. This table shows that for intubated and non-intubated patients in ICU. So we see for secretionist and in non-intubated patients the type of oxygen, nasal prong, face mask, or high flow nasal cannula, or non-invasive CPAP. But so see also the pattern of breathing, the respiratory rate, effort, and whether there is cyanosis. Also, in intubated patients, see the ventilator setup, especially the plateau pressure and the peak airway pressure. So, and also see for the auto PIP, and also arterial blood gas analysis has to be sent, and also so see for the desynchrony, and see for the pulse oximetry reading, saturation, and see for pattern of breathing and respiratory rate. The other is on palpation. So check for oxygen